Click up in the upper right hand corner where there's the 3 dots at the bottom. You should be able to rename it. So yeah, you got it.
Okay, hello everyone. I anticipate that we are going to have more people signing on in the next couple minutes, but we wanted to start promptly at 11. My name is Emily Nolan Pluchek, and I am an attorney with the Public Defender's Office in Stevens Point. I am the interim president-elect of the WATCP Board of Directors. I also have served as a public defender representative on the WATC board, and I was president of the WATCP board a couple years ago. Finally, my most important and my favorite role is that I am the public defender assigned to the Wood County Adult Drug Treatment Court. On behalf of WATCP and the UW School of Pharmacy, I'd like to welcome all of you to this webinar on the use of naltrexone in treatment courts. Today's panelists include pharmacists from across the state of Wisconsin, some of whom are affiliated with treatment court teams, and Dr. Ford from the UW School of Pharmacy. I am now going to turn the webinar over to Dr. Ford, who can do the rest of the introductions and let you know how the format will run today. Thank you.
Great. Thank you guys very much for joining us today. My name is Jay Ford. I'm an assistant professor in the School of Pharmacy here at the University of Wisconsin-Madison. I'm privileged to be joined by several pharmacists who are working diligently in their communities to provide injectable naltrexone. So I'll let them introduce themselves first real quickly, and then I'll circle back to the planned format. So John, I'm just going to start with you because you're in my upper left-hand corner.
Okay, thanks, Jay. My name is John Lemke. I'm a pharmacist up at Stru's Pharmacy, Bay Natural in Green Bay. We've been an independent pharmacy for over 60 years now. I've been working there for the last 6 years, and it's been about almost full 5 years now that we have been doing long-acting antipsychotic, and in particular Vivitrol and naltrexone, the long-acting naltrexone injections up here in Green Bay.
Thanks, John. Mike?
Hi, my name is Mike Kukas. I am a partner with a hometown pharmacy in Monroe, Wisconsin. We've been here about 3 years. I was a shop co-pharmacist before this time. So I've been practicing for over 30 years. Been doing Vivitrol and long-acting psychotics for about 3 years now.
Jenny?
Hi, I'm Jenny Villeneuve. I am at Murdoch Hometown Pharmacy in Oshkosh. I have been with Hometown for 8.5 years now. And I think I've been doing Vivitrol and long-acting antipsychotics, I want to say about 5 or 6 years. And had a pharmacy student a couple of years ago that was kind of working with you, Jay, and with a couple other people, just kind of starting to poke around to find out how we could get paid, a fee for doing our injections, just to get paid for that service and the consultation that goes with it. So that's me.
Great, thank you. And Nick?
My name is Nick Smith. I'm a pharmacist and owner of Smith Pharmacy. Our pharmacy is about almost 9 years old. We've been doing Vivitrol for about 3 years, working with 2 physicians. We're a pharmacy in Little Chute, Wisconsin. We're heavily involved in compounding, long-term care, and a lot of MTM type things, and just pharmacy practice in general and advancing the pharmacy practice.
Great, thank you. What we're going to do on the webinar today is I'm just going to literally spend about 2 or 3 minutes providing you with just some very high level, background information that we've learned in our conversations with John and Mike and Jenny and Nick and others across the state about Vivitrol injections. And then I've got a series of questions that I'm going to ask them to respond to. I would encourage you, as you have questions, to put those into the Q&A so we can answer them as we go. But before we do that, I'm wondering if we had 2 polls that we'd like you to respond to. So I'm wondering if we could just pull the first poll up and let people take a minute to respond to that. And then we'll do one more afterwards. Emily, I'm going to have to depend on you. I'm seeing the poll, but I'm not seeing the results pop up. So if we've got enough people responding, then we can close this poll and go to the next one.
So we have about, here we go. Now they're filling in. Come on, there's 4 more of you out there. Just check a box. It's about 80% have participated. Are you able to see the poll responses?
No, I'm
Okay.
not.
So we have 56% of our viewing participants are in an adult drug court. 13% are with an OWI court. 19% are with the hybrid OWI drug court. We have 1 person from a mental health court. We have 13% of the viewers today are from Veterans Treatment Court, 19% from the Tribal Healing to Wellness Court, and we have 1 person as well from the Family Dependency Treatment Court and 1 from a co-occurring disorders court. So every court represented, and the largest being, of course, drug courts, which do comprise the largest number of treatment courts in the state.
Okay, thank you. Do you mind popping up the other one really quick, and then we'll.
Not at all. Yeah. As soon as I find it. There we go.
Won't let me vote.
No.
As a panelist, you don't have that privilege. All right, it looks like just about 88% of the folks here have voted. Yes, 70% of them have voted yes, that they believe that it's feasible to begin referring participants. 13% said no, and 19% felt that it was not applicable.
Okay, great. Thank you. So I'm just going to quickly share my screen here and run through the slides. So what I really just wanted to share with you a moment is just kind of what we've learned so far about injectable naltrexone services at community pharmacies. We went through a process to try to explore how different community pharmacists are providing this service. We did that through a series of surveys and interviews with pharmacists from across the state. And we've been able to use that to identify some service delivery models as well as some best practices related to this service in community pharmacies. So in terms of the service delivery models, there's basically three. I think the simplest way to look at this is one model is where the pharmacist is just providing the injection service and everything else is kind of happening outside of the pharmacy. Another one is kind of where there's a mix that, again, the pharmacist is providing the injection, is doing the urine drug screen, but they're not doing any in-house behavioral health counseling. And then the third model is where the pharmacist will actually connect the patient via video with a behavioral health specialist to have that counseling session prior to giving the injection. And how these different models work may be things that our panelists want to talk about as we go forward. And then what we've also learned is just that the process tends to involve, a series of steps, and we identify some best practices around these. Essentially, these steps can be grouped into pre-injection activities, things that happen prior to the injection, like benefits coordination, doing some extended patient consultation about the medication, its risk, and again, if necessary, that behavioral health consultation. Then obviously the injection delivery activities are really preparing and providing the injection and then monitoring the patient for reaction. And then after the injection, activities might involve follow-up with the patient, administrative documentation, and then billing of the services, as feasible. What we have learned and what kind of led us to this point is we did a survey earlier of members of WATCP and pharmacists, and we found that for pharmacists that about 33% said they were getting some of their referrals from drug courts. But when we looked at the responses from treatment court coordinators, at least those who responded to our survey, only 3 out of 20 indicated that they were aware that a pharmacist could offer injectable naltrexone. And at that time, no treatment court coordinators were reporting that they were actually working with community pharmacists to provide the service. And so these results kind of informed a need on our part, to kind of create this networking opportunities for treatment court coordinators and community pharmacists, to have a conversation about injectable naltrexone services in the community pharmacy. So that's just kind of it at a very, very high level. I didn't want to spend a lot of time, talking about that today. But what I did want to ask the panelists is, from your perspective, and you guys could just jump in as necessary, what are some of the principal benefits that you see of a pharmacy being able to provide naltrexone injection services? And then we'll talk about that, but we'll also talk about a question or something that's already come up in the chat in a moment. So.
Well, I can speak to some of the advantages for the community-based, pharmacy-based receiving of the long-acting naltrexone. One of them is that there's a lot of availability. My particular pharmacy, the appointment schedule doesn't look like it does at the doctor's office. It's easier to get in, it's easier to get out, and that makes it a lot more convenient. Plus, a lot of our folks also have accessibility issues. And many of the folks who do receive it don't have their own driver's licenses, for example, for a number of reasons, some related to court. Being available to folks, as far as transportation goes with, bus line accessibility, other things like that, having connections to referral to sources such as the 211 Wisconsin or other rides that can be given to folks through different agencies. There is also an affordability issue. It doesn't cost money to make an appointment to go through a community pharmacy to receive this. Also, we are available to help manage cost problems that might come up. Of course, long-acting naltrexone injection is a very expensive medication. Not every insurance covers it. We are able to help with that benefits management. One thing we have found is that there's a level of anonymity that goes along with a patient receiving an injection at a community pharmacy, as opposed to other venues where it may be more of a stigma associated with where someone's going and understanding that they're going there for other reasons, whereas there's a lot of reasons you'll come to our pharmacies.
Thoughts from others about the benefits?
I think John pretty much stole all our thunder. I think he queued up everything. That's everything that I was going to say. Just curious, John, how come you're not charging anything for the time that you spend doing this?
Well, we will be. Senate Bill 255 has passed, so hopefully within not too long, we'll be able to do that. We have two reasons for not charging. One is when we started this program, we really did want to jumpstart sort of transforming our industry as a pharmacy to get away from that retail model to one where it's more community-based and more professional healthcare services based. And two was to help demonstrate the value through other things we'd be doing, such as through our CPESN network or WPQC, to try to demonstrate the value of pharmacy such that bills like Senate Bill 255 could be drafted and passed.
Interesting. We charge $30 per visit. Most of my patients pay that gladly and happily. I've just learned in the past with my 30 years of experience that if you don't give a value to something, there is no value to the patient, or come to be soon legislators. So that's just my 2 cents. I was just curious, but I understand that too.
Yeah.
This
Go ahead, Nick.
John stole our thunder as well, or my thunder. Basically he hit every point that I was going to state. One thing is a relationship with the physicians. We work with a couple of the physicians, and that's a nice bonus. Another thing is obviously being a pharmacy owner, you're getting new customers walking in the door. They see your pharmacy, they trust your pharmacist, they talk to their neighbors about it. And so it's, that's a bonus too. It's exposure, advertising. We as well do not charge. And you have made some very valid points. The main reason is almost all our Vivitrol injections are for the Medicaid population. So I'm not even sure legally if you could charge. I guess I don't know where that line is, but with Senate Bill 255, that will change. And I'm sure Jay will get to it down the road. But like when I talked to Dr. Ford, financially, it's not really sustainable. It's not profitable right now doing Vivitrol injections, but that's not the goal behind why our pharmacy does it. It's about doing the right thing. But when you're paying a pharmacist $1 a minute, and I looked, we make about $30 on a Medicaid prescription for Vivitrol. We're spending more than 30 minutes with that patient. So obviously it's not a profitable model, but it's more, doing it, to, forward the practice of pharmacy and doing the right thing.
Jenny, you have any comments that you want to share about the benefits?
I would say I would echo everything that everyone has said up to this point. I also do not charge an injection fee for giving a Vivitrol injection. Like Nick, most of my patients are Medicaid patients. And again, for legal reasons, I just haven't wanted to cross that line. So I'm with you 100% on that one, Nick. I would say the one thing that I haven't heard from anyone else, and I don't know how all of you feel about this, but I get a lot of professional satisfaction out of helping this patient population. But I think, all of us are pharmacy owners on this, the four of us on the panel right now. And I think even though we own our own pharmacies, none of us got into this to make money hand over fist. We got into this to help our patients and to be members in our community. And I have found the relationships that I develop with these patients month after month when they come in, feeling like I can be an additional coach for them. I can be their cheerleader. I can encourage them. I can make them not feel bad if they slip up, and just get them back on the right track. That brings me an incredible amount of professional satisfaction.
Great, thank you. I want to, before I move to a question that was in the chat, I want to ask one of the questions that's in the Q&A, and just especially maybe Jenny and Mike, from your perspective of working with Hometown, and then Matt with with the Forward Pharmacy. I'm wondering if you guys can help answer this a little bit, and that is, Autumn asked whether or not all pharmacies are willing to provide this. If not, are there a list of pharmacies that offer naltrexone? I think, at least from my perspective, most of the naltrexone injections are being offered at community pharmacies. This is not something that I'm aware of that chain pharmacies like Walgreens or CVS is doing in the pharmacy. But I don't know overall with Hometown or with Forward Pharmacy, if that is, if all Hometown pharmacies or all Forward pharmacies are in a position to offer this service if somebody walked in the door. I don't know if you guys could maybe address that.
Jenny, do you want to address it?
Well, sure. I don't know how it is in the southern part of the state for you, Mike, but for me here in the Fox Valley, the other hometowns will refer patients to me. Most of the other pharmacists in the Fox Valley hometown network don't necessarily love doing Vivitrol or other long-acting antipsychotics. I think we're probably all set up for it. I would assume most of the pharmacists within our area have done the training, but I think just don't have the comfort level for it. I have had instances where patients will bring in a Vivitrol that they picked up at, say, like a CVS or a Walgreens, and they'll say, well, the pharmacist gave this to me. I have no idea what I'm supposed to do with it. Do I give it to you? Do I bring it to my doctor's office? So it's interesting to me that those pharmacists at those other pharmacies aren't necessarily doing the proper consultation. They're just handing the product over and saying, okay, my hands are clean and have a nice day.
Hometown seems to support us for if we do want to venture down the Vivitrol path. We do stock it in our own warehouse, so that makes it easiest for to acquire it. So everything is there. You just need to have the desire of the pharmacist to go forward with it.
One thing to note too is, like Jenny and Mike said too, you need to have the right setup for it too, because it's a gluteal injection. Obviously, you got to have a somewhat or a pretty extensive room with some privacy and no cameras. And there's a little bit of planning involved too, because ideally the patient, you would schedule an appointment and the patient would, so you can have it unthaw, or not unthaw, but have it come to room temperature. So for an hour or so you can reconstitute it the correct way. I know we've done it before without that, but so a little bit of planning involved, but I think a lot of pharmacies, a lot of the chains don't have the privacy room, the vaccination room required for a glute injection.
Yeah.
You go to the Vivitrol website, they do have a provider or an injection site finder for the state of Wisconsin. I think if you go there and look, you'll find it's almost all independent pharmacies, if it's not the actual treatment centers themselves.
Emily, did you have a question you wanted to?
No, that was an accident.
No, okay. All right.
Nor my hand.
All right.
Thank you.
So a question that's in the chat before I move on with some of the other ones is Kid expressed that they're most interested in injectable Suboxone, and wondering if you guys would be able to speak to that, any advice, any barriers related to providing injectable Suboxone.
One of the big barriers there is that the manufacturer of that you have to get set up, and you do require that is something that is required to be administered by what is defined, if I'm not mistaken, this as a healthcare provider, which has got vague definition from the manufacturer and from their prescribing information. Maybe some of the other pharmacists can know more about this. I haven't looked into it for several years.
Yeah, I looked into it.
You
but-
did. We tried and got nowhere.
I agree. I tried looking into it. I didn't get anywhere either.
It appears, at least from what I know, that it's a risk evaluation and mitigation strategy, REMS, that there's documentation that has to be completed to do that. And then there's some steps, program requirements, but most of them that I can tell by looking at it seem to be that the pharmacist is establishing policies and procedures, or process and procedures, to verify that Sublocade is being dispensed to the healthcare provider, and it's not being dispensed to the patient, and other policies like that. I know if she had been able to join us, Lisa Bonner, who's with Genoa Health in Racine, that they are providing these injections, and so several of their pharmacists have gone through, I guess, the training or the certification process to obtain the REMS. It looks simple on the website. I mean, it's a real simple form, that you check a couple of boxes and then somebody signs, but things that look simple aren't necessarily simple in the background. So I think that may be in part, Kit, the issue is that there are barriers that exist from the manufacturer's perspective, that you have to be REMS certified. And I'm just guessing that it's not something that a lot of pharmacists have looked into. It sounds like you guys have looked, but haven't been able to figure that out. So Mike, I wanted to ask you this question, and then maybe others can jump in, but I know in our conversations, that you have an established relationship with, the treatment court there in Greene County. And I'm wondering if you can kind of talk a little bit about how you initiated that process, and then what steps you've taken to kind of maintain that relationship with the folks in Greene County.
I guess just like anything, sometimes things just drop in your lap. I have a customer that was a counselor. Just talking to him, I said, so if I ever wanted to get involved with something like this, who would I talk to? Where would I start? I really knew nothing about it. So with his help, he got me connected with some people, and now it's more word of mouth than anything. Someone finds out that you are doing these injections. I never advertise about it. It's not really high volume for me at this point. I don't have the time to make it high volume at this point. But just talking to people and getting the word out, and other people talking about it, is word of mouth is the best way. Does that kind of answer your question?
Yeah, no, it helps. Thoughts from others that might be working with the treatment court or in your county. Have you had any success in connecting any strategies?
Not yet. I spend my day giving COVID vaccinations. I spend my day doing COVID testing. COVID has just kind of taken over everything here at my pharmacy, and I'm sure all you guys would agree with that. Sometimes you have to go where the service takes you, and sometimes it takes you where the gross margin takes you. And for right now, that's what we focus on. So I hope to get back into doing more tracing, so to speak, on getting more involved with Vivitrol.
Okay.
I think that's really the next big hurdle with this, is the breaking down of the silos in which we operate. Everybody, as Mike says, we're all very busy within our own domains here. But I think there's also a willingness to really establish these connections. We do both. I think everybody sees that this has some great advantages. However, just getting that catalyst, that get over the initiation energy, as it were, here. I think everyone's willing. It's just a matter of setting precedent in some way. I'm sure it's doable, but it's not serendipitous like it was for Mike. It's really more of a trial and error thing, or something that comes up ad hoc. That's how it's been in Brown County anyway. We don't really have anything formal per se, but just as we've crossed paths, it's worked or it hasn't. It's a work in progress, really.
Yeah.
Okay. Great. Nick or Jenny or Matt, any interactions that you might have had with treatment courts, or any thoughts about that process?
Yeah, this is Nick. I didn't really work per se with any treatment courts. In following Mike kind of hit it perfect, kind of just fell in my lap, because, you know, it's something we were willing to do, and it's something that we would, you know, help anybody out. But to be honest, it's, you know, there seems like there's other things that keep pulling us away from it. And especially that it's not a real profitable thing. It's not something that we're like actively seeking out, but if it falls in our lap, we'll do it. But it is pretty neat, like what Jenny said too. It is pretty neat getting to see the same people come in every month and get to know their story and get to know them personally. And it is very satisfying. That was a very good point that she made. It's really neat seeing people. These are people that are trying to improve their lives. These are not people that are, you know, a lot of people have the bad stigma that you're going to be bringing all these bad people into the pharmacy or bringing a rough crowd in, and it's not that at all. These are people that are trying to improve their lives, that are actively working for it. So it is very satisfying to work with them. So I will certainly always take a customer, but it's we basically have just taken what's fallen in our lap. We haven't actively sought out anybody or any clinics or any courts.
One of the questions that's in the chat that I'm hoping everybody can just respond to, and I'm going to add a part to that is folks are interested in knowing what is your monthly volume of Vivitrol injections. And then I'm also wondering if you guys, you know, as you're answering that, you could maybe talk about, you know, are you providing this for individuals with an opioid use disorder, you know, and or an alcohol use disorder, you know, whether currently or in the past. So
We've doing for both. In fact, I think we have more alcohol dependence disorder patients right now than we do for opioid. And I think anecdotally anyways, we have a lot more success with alcohol dependence patients than we have with opioid. I'm sure part of the nature of that is the severity of addiction, but also maybe it's just up here in Brown County. It seems to be that we have a lot more cases of such, but we do, it varies from month to month, but anywhere between half a dozen and say 12 to 15 patients every month.
I guess I'm pretty low volume compared to that. I'll do 1 to 2 a month. Most of ours are alcohol related.
Yeah, I can echo that. We do, right now, I think we're currently doing like 2 a month. At one time, I think we were doing 4 or 5, but most of ours are opioid related.
I would say mine range, I would say most months I do a minimum of 8. There have been some months where I've done as many as 25. During the shutdown part of COVID, I was doing close to 25 because I was the only place in this area that would give them, because our county health service was not able to give them. So I would don my mask and my shield and my garbed all up, and they had to come in my back door, and we did them in the back stock room because I didn't have anybody coming in my pharmacy. Now that the shutdown is over, I'm probably between 8 and 15 a month. And I would say split down the middle between opioid and alcohol use disorder.
Matt, how many are you guys doing a month? I do know that other pharmacies that are offering the service, they do have a mix between the opioid and alcohol use disorder. I know one pharmacist that was hoping to, join us today, but wasn't able to. I think, he's primarily seeing, folks with an alcohol use disorder. So, it is a mix of things that folks are seeing. So I'm wondering, there's another question in the chat that I will kind of defer to the panel, and that is, are you guys aware of any kind of relapse statistics, when someone maybe switches, to injectable, Suboxone? Again, I know you're not providing it, but are you aware of anything about, relapse when folks, switch over to a monthly injection of Suboxone? So,
Do we have any experience with patients who've made a switch to the injectable Suboxone?
Neither have I.
so I will say what I heard from, in talking to some providers that, when we ask them this question, their response was they usually try to make sure that the patient, they try to figure out the right dose of oral of taking the daily, Suboxone, and get the patient to a stable kind of position before they would potentially recommend switching them over to, the once a month injection. So they try to gauge it by the patient. So I don't know, Diane, if that kind of helps, roughly answer your question about at least how providers look at this process. Another question I have for you guys is I know sometimes, just by nature of the clients that you're dealing with, they no show. So how do you kind of process, when somebody is scheduled to come in for their appointment, but they don't show up? I mean, what do you do in those situations?
Well, I can speak a little bit to that. You actually raised a really good point about something that underlies that, which is the pharmacy staffing and resources to do a lot of the pre and post work. A lot of technician time is required to do a lot of the following, setting up reminder calls for appointments, calling if there's a missed appointment, trying to do rescheduling. Our process, we're fortunate in that at our pharmacy, we do have some nurses working for us. We have a large long-term care pharmacy, so there is staff to be shared to do this. And when it comes to the missed appointments, the biggest problem we have here is that the long-acting naltrexone, the Vivitrol, can only be taken in and out of the refrigerator 3 times. And prior to a patient's arrival for the injection, we need to have that out for a minimum of 45 minutes before we can prepare that injection. When we have a no-show, that has to go back into our refrigerator. And our policy is after 2 no-shows that the patient in question does have to arrive and stay in the pharmacy for the full 45 minutes for the injection to warm before we will administer. Which of course has a number of challenges, but that's how it is. And right now, we go through that multiple times. We haven't figured it out yet. Maybe some of the other pharmacists have, but a point where we end up discharging a patient as well for too many no-shows and failure to commit to the program.
What we've done in the past is have them call us ahead before they head in. Quite a few of my patients, they actually get a urine analysis done by the county before they come in. So I'm actually made aware when they're coming in. So I haven't had too many issues of taking it in and out of the refrigerator. But I have had a fair amount of no shows.
I do what Mike does. I do have my patients call me the morning of their appointment just to confirm that they are indeed coming. I would say I have very few no-shows, and occasionally I even have drop-ins. So for those people who walk in, they know that they do have to wait a little bit longer for the, medication to come to room temperature before administration. But I would say that the no-shows have been handled primarily by having the patient responsible to call me the morning of.
What about on the flip side? The patients come in, that you've given them the injection. What type of information are you usually sharing back with the, the individual that has referred the patient, to you for the injection?
I typically don't have much follow-up unless the counselor calls me.
Okay.
We have it's kind of a standard documentation form, somewhat follows the SOAP note that we fax to the prescriber, and if necessary, back to if it's requested by an AODA counselor or whatever, to share the basic information about patient having come to receive the injection. For folks who do not make their appointments, after a trial of follow-up on our end, we do contact the provider or whoever else may be requested to be involved in this process that patient did not show, and inform them of that, I guess.
Okay. Nick, you were going to say something, I think, so.
Yeah, we had worked with a doctor and kind of wanted, we seek out what information he wanted as well. We have a standard form that basically, kind of goes through a lot of the preemptive questions. We put a copy of our prescription label on it. And it's got, lot number, expiration, what glute, what size they got, negative, pregnancy test, if that's valid. Patient sign, pharmacist sign, and then we always fax it to the doctor, and then we docu-store it for our records. And a lot of times we'll make a copy for the patient as well, so they can have something again that to show the physician that they received it on this date. But yeah, nothing really special, just a form that we fax.
As one of the things I would just be curious about, just as a follow-up to that, and this is more for the participants on the call, you kind of heard what John and Nick and Mike and others have said about the types of information they share back with a referral source. Would be curious that if you had referred a patient or participant from the drug court, to one of these pharmacies, and you've heard what they've said they would send back to you, is that the type of information that you'd be looking for, to hear from them, or is there something else that you'd want to receive back from them about, your participant that has gone to their pharmacy? So if folks have thoughts about that, please feel free to just drop them in the chat, and we kind of read them off as they show up in the process. Diane, I did see your other question about, the safety of Suboxone long-term and some of these other issues. I certainly don't know the answer to that question, but I do have some colleagues that are providers that I will pose this question to, and depending on their response, I'll share that back with Emily and Jody so that they can share it with the rest of you. Okay. I think what I'm also hearing is about the 7-day drug abstinence required to get Vivitrol, and whether or not that's the same for Suboxone. And I don't know if you guys know if that's, from a clinical perspective, is that kind of the same requirement? Are you guys aware of that as pharmacists, about the drug abstinence to be able to get Suboxone, or maybe even the injectable? Do you have any knowledge?
Really the key difference between Naltrexone and Suboxone is that the patient does not have to go through withdrawal to initiate Suboxone. Of course, with Naltrexone, the patient has to go through withdrawal just by nature of the drug itself. So that's why the waiting period exists for the Vivitrol injections.
Okay. All right. Another question I had was, if you're working with a treatment court who is referring a participant to your pharmacy for an injection, what type of information would you want to get from the treatment court about the participant?
I guess what I would like is obviously we need the patient demographic and contact info, number one. Insurance information would be very nice. But we could get the insurance information by obviously contacting the patient. And then I guess lastly, what information do they want us to send them? What information do they want us to, we'll fax a provider, obviously the information that we normally would, but should we be sending, this information to another third party? I guess, every provider wants, their own little, pre-screen checklist. They're all going to be pretty similar, but I guess it would be nice to know what the, what the provider is actually looking for and what follow-up information they would want from us.
Okay, thanks.
Couple of things that we've run across is that if the patient has already received a Vivitrol injection prior to, say, leaving the facility they're in, we need to know when they're next due for it. We need to also know which physician would be following the patient and providing the prescriptions afterwards. We've had a number of times where we've had no refills on the order to inject, and the patient didn't even have a psychiatrist or somebody who would be a doctor at all, in fact, to prescribe. So those are the kind of things that also come in quite handy.
One piece of information that's helpful to me at times is if the patient has tried oral naltrexone tablets prior to administration of Vivitrol. With those patients, I have a little bit more confidence in the safety of the medication, knowing they've come in at least doing a trial on tablets. So that's useful information to me.
I guess it might be helpful if we know they're receiving the Vivitrol for alcohol or drug abuse, just to give a little background on them.
We're going to need that diagnosis code to bill it in the first place. So
Yeah, true.
mm-hmm.
So a question I have, this is more for the participants on the webinar. And so if you have some thoughts, I'd be curious for you to put them in the chat. Is, if you were looking to establish or consider referring a treatment court participant to a community pharmacy for a Vivitrol injection, what would you want to know about the service that's being provided at the community pharmacy, before you did that? So, if folks have some thoughts about that, I would encourage you to just drop some of those in the chat. But so I know, Mike, you talked about a little bit about, the urine drug screen, that a lot of times that's done at the county level before people come over. But what is your guys' typical process for, administering a urine drug screen prior to giving the Vivitrol injection? Is that something you do routinely with your clients? And could you talk a little bit about that?
I guess it depends on the patient, and it also depends on the counselor and where this patient is coming from. I usually try to discuss that with someone other than the patient before the patient comes in. So I'm kind of prepared if I need to do a urinalysis or not. But that's one of the things that we can collect before the patient even arrives, is just have that knowledge if we're expected to do it or if they're coming from having that urinalysis done.
Okay. Great, thank you.
I require each patient to do a urinalysis every time. I don't give them, some of them come to me from a treatment facility down the road for me, and they'll say, oh, I just took one an hour ago. I still want to see it with my own eyes. I always require it to be on site when they get here.
Okay.
I think for liability, we do the same thing. One thing I will add, though, is that I find it's important to communicate to the patient that we are collecting the drug screen for their protection. I have had patients who they won't express it, but are concerned that we are going to share the results of that information with the people who they don't want to share that result with. I do inform our patients that I'm looking for the presence of opioids. If they are absent, that's all the information I'm sharing with their doctor and their doctor alone. I've been surprised by a number of patients who later told me that they had canceled their appointment because they had smoked pot in the past 28 days. That's not going to prohibit me from administering the injection. So there's some level of patient education that needs to take place.
I totally agree with that. I tell every patient when they come in, the first thing I say to them is, this is a no judgment zone. I'm so proud of you for being here. I commend you for having the courage and the bravery to be here. I don't care what's in your urine as long as you don't have opioids. And I think that gives them a sense of trust and a sense of comfort.
Great, thank you. Other questions from the, if there are questions from the folks that are on the webinar, please feel free to drop those in the chat or into the Q&A. I'm trying to think of, as you guys are thinking in general, just about how, the questions that we've talked about, the topics that we've talked about, I'm sure I've missed something, in terms of just thinking through this relationship, potential relationship between treatment courts and community pharmacies. So I'd like you to, share what you're thinking about that in just a minute. There is a question about, as you're looking at the urine drug screen, are you looking at other substances like meth or non-prescribed stimulants as part of that process?
No.
No. Okay. And then another question that's come in is how are, as pharmacists, what are you doing to kind of assist with the cost of naltrexone? So are there steps that you're doing to try to assist with the cost of the medication?
One thing to note is that if the patient is covered by Forward Health, that it's as long as we have the diagnosis code, that is covered at a cost of no more than $3 for the patient. And as per the agreement with Medicaid, we can't refuse to dispense the medication to a patient who does not have the copay. So there is a great amount of availability there for folks who are on state assistance. Also, the program, Vivitrol itself does have a discount card program for those who have just private insurance. And I am unfamiliar with there being any foundation or grant source for folks who do have a government-sponsored plan and do have a high copay. Maybe some of the other pharmacists have run across one. I have not found one that covers that disease state.
The only thing I've run across is in Winnebago County. They have a grant through the state of Wisconsin. And if a patient meets their qualifications, like through our local human services department, they'll refer the patient here. And then I bill the county for the cost of that medication, and there's an administration fee built into that. And then that gets paid for through this grant funding. But other than that, that's all I've come across.
Mike or Nick, anything about that you're doing to try to help with the cost of the medication?
I know Greene County has a benefit also like that some patients do get their costs covered by the county. Unfortunately, I am yet to be one of those pharmacies that can accept that payment from the county. So they actually get it filled at another pharmacy and then come to me for the injection.
To be honest, most of ours are through medical assistance. So like John stated, it with a diagnosis code, you can get it covered for $3 or less. We've had a few commercially covered patients that we worked and got a PA approved. I was actually just looking on Needy Meds to see if there is a manufacturer savings card. But we honestly, 90% of the ones we've done are with medical assistance, so we haven't really went down that road too much.
Great, thank you. Just getting back to my other question. Go ahead, Nick. I think you were going to say something. I'm sorry if I interrupted you. So.
Oh, no, I really didn't have, there is a manufacturer savings card available for cash paying customers, but like I said, we haven't really went down that road. I'm just actually clicking on it right now to see what kind of benefit it is, but it looks like there is some options out there.
Okay. So here's a question in the chat that says, if the UA is positive for opioids, but the client is at or within 28 days of the last injection, would you be comfortable administering if the prescriber has discussed the risk of possible withdrawal with the client and the benefits outweigh the risk of administering?
I personally would not.
I do think that's something that has to be done in a clinical setting where there's more monitoring than can be provided. Although we are set up to handle acute reactions, I don't believe it's in the best interest of the patient to have that happen in our setting.
Right.
I would agree.
Yeah, that's very well put. That's exactly how we would handle that.
All right. But just as a follow-up, I mean, as you guys have set up the program, have you put specific policies and procedures in place, in the unlikely event, that somebody has a reaction to the medication, that, was not maybe covered through your analysis? I mean, do you have a policy or plan for how you address those rare events?
We've had a situation come up once where a fellow who was court referred did fake his urine drug screen. He did use someone else's urine to pass it, and later did call us with withdrawal. We our policy there is we will discharge a patient, as we had to, unfortunately, for this particular individual, for violating the rules of our agreement.
Okay.
One thing to note.
Oh, go ahead, John. Sorry.
I was simply going to add one thing I meant to mention earlier, which is as far as that 7 to 10 day waiting period, for anyone who, I'm sure all the pharmacists here know this, but methadone has a very long half-life. Patients who would be switching from methadone may require longer time for that, or may require they're going to have to simply go through the withdrawal regardless of the amount of time that it is when we would give an injection.
Mm-hmm. So to answer the question, Jay, that you posed, I do have 2 fire stations within very close proximity of my pharmacy, and I have notified both of them at least on an annual basis that I'm still administering Vivitrol, and that there may be instances where I would need to call them. I did have one patient one time who, within 5 minutes of giving Vivitrol, experienced a seizure and fainted at the pharmacy. It turned out it wasn't because of the medication. He was an alcoholic and he did drink, and he was like an acute pancreatitis situation. But because I had previously notified our local fire department, the paramedics were able to respond within 3 minutes. So I do make that phone call at least once a year to remind them that I am still indeed administering the medication. And if I need them, are they still available to me quickly? And it's a nice relationship to have with them too.
Great, thank you. I know we're almost at the top of the hour, so we probably have time for one more question if there is one. And in the meantime, I'm wondering if we could just put up the last polling question that we had, and if there's another question in the chat, we'll try to answer that in the next 2 or 3 minutes. So while Jody, again, I'll have to depend on you to kind of tell us when enough folks have responded and what we're hearing, seeing what the results are. So
just waiting for a couple of more folks here.
okay.
So far, we've had a handful of people respond, a couple more coming on. And it looks like it's like watching a horse race. So we have just a handful of folks voted. Of the 9 people that, oh, here we go, 10. See, as soon as I speak, they want their vote counted. Your vote matters. All right. We have 3 yeses, which is about 30%, 2 no's, and 5 or 50% not applicable. So
Great, thank you. First of all, I want to thank everybody for taking the time out to join us, but especially I want to thank John and Mike and Jenny and Nick and Matt for joining us today. I hope this has been beneficial for everybody to kind of understand, the opportunities that are available for community pharmacists and treatment courts to connect to provide this service. I do understand that, some of the important issues for some folks are related to the long-acting buprenorphine injection for the Sublocade. We'll try to get some answers for that, and I know, down the road that might be another opportunity. But I do want to thank each of you guys for joining today, taking time out of your schedule to be a part of this webinar today, especially for John and Mike and Jenny and Nick and Matt. So thank you guys very much. I hope it was beneficial for everybody.
And I'd just like to thank all of you for providing this information to us as well. This webinar was recorded and will be available on the WATCP website on our resource page very shortly. So thank you again.
Great. Thanks, everybody.
Bye.
Thank you.